Marginalized population challenges and barriers.
Thank you. Okay, so these grand rounds are actually a group effort that we put together. So it's basically presented by the hemodialysis group. So the three physicians here who do most of the hemodialysis care at St. Paul's, myself, Dr. Farah, and Dr. Jung, and Stan Marchuk, our nurse practitioner, and one of our renal social workers, Allison Rose, going to do this talk with me. So over the next hour, what I'd like to do is to give you guys some cases that we've been involved in, that actually a lot of you may know as well, because they've been patients who've been admitted in the hospital a number of times, and just go over the challenges that these cases present to the patient and to the care providers. And then I'd really like to spend some time to go over the risk and the potential complications that arise when we are in a position where we have to do intermittent or emergency hemodialysis, and what's the concerns that we have, and why are we reluctant to do it. And then hopefully at the end, have a proposal about how we can try to improve the outcomes of these patients who do need chronic hemodialysis with a team approach. So the first case that I want to present is a patient, again, known to probably many of you. So this is a 49-year-old male. The other thing is that sometimes you see these patients during their inpatient, and then they get discharged to continue with chronic hemo. But I'm not sure if everybody knows really what happens to them when they get discharged. So type 2 diabetes, hypertension, peripheral vascular disease, history of IVDU, hepatitis C, which was untreated, recurrent admissions to the hospital with foot infections and osteomyelitis. He developed stage 5 chronic kidney disease, and he had biopsy-proven infection-associated GN and diabetic nephropathy. He was referred to our kidney care clinic, but unfortunately on a number of occasions did not show up. He had multiple episodes where he got admitted to the hospital and required intermittent hemodialysis, would be discharged, given a chronic dialysis schedule, and wouldn't show up. So this happened a number of times, and then he would come in with line infections, get the line out, put another one in, same thing. So then eventually we had a multidisciplinary meeting, and we met with him and his family, and we deemed the patient not to be a chronic hemodialysis candidate. We did offer him to follow up with our kidney care clinic, but he didn't show up. And then eventually, actually, we found out that he showed up at Vancouver General Hospital, was admitted to medicine, and then left AMA, and then eventually passed away. This is a case that we were recently involved with in the ICU, so some of the ICU team will remember. 51-year-old male, history of polysubstance abuse, hypertension, hepatitis C, type 2 diabetes, previous CVA, cellulitis, and osteomyelitis. Again, he had recurrent episodes where he got admitted to the emergency with AKI on his CKD and required emergency hemodialysis, and then developed complications regarding his hemodialysis line with thrombi and recurrent thromboembolism. He actually was on and off dialysis, doing sort of intermittent emergency dialysis since 2016. He first presented at Fraser and he sort of wouldn't show up for the chronic appointments, and then ended up in Vancouver General Hospital and sort of same sort of history, and then ended up at St. Paul. So it wasn't a new thing here. Again, when we discharged, patient was discharged, he didn't show up for his chronic hemodialysis appointments. He showed up once, and then 10 days later came, was unwell, didn't tolerate dialysis. Anyhow, so we had a meeting with him, and we told him that unfortunately he was not a dialysis candidate because he could not adhere to the dialysis schedule. He actually agreed and said, take my catheter out. So we took the catheter out, and then he wasn't seen for 6 weeks. And then he presented to the emergency department with a hemoglobin of 26, with a creatinine of 960. I think he lasted that long because he was slowly bleeding. Anyhow, so then when he was resuscitated and he could actually be awake and tell us his wishes, he said, I want to have hemodialysis. So what do we do here? Like, do we do the whole thing all over again? This is a case that I think we're currently dealing with. This is a 37-year-old female, First Nations, polysubstance abuse, hepatitis C. She was initially admitted to ICU after being found down by the ambulance, and she was having tonic-clonic seizures. She was found to have necrotic toes. She was an anuric renal failure and started hemodialysis in the ICU. She was seen by addiction medicine and actually had to be sedated so that she wouldn't leave the ICU. And then the following day, she said she wanted to leave, and it was felt that she could make her own decision, and so the line was removed and she left AMA. And then 2 days later, she came back, confused, hyperkalemic, again admitted to ICU, had a new line put in, and then the next day left again with the line. So of course, a couple of days later, readmitted with line sepsis now. The hemodialysis line was removed. She had to be certified and sedated, and then a new line was put in, and then she had her hemodialysis. And then after that, I think there were some issues. I wasn't involved in this point. Do we just continue to certify her so that we can continue to treat her? But I think that eventually it was deemed that she could actually make her own decisions. So she actually left AMA with that tunneled hemodialysis line in place, and I think she's just returned. So I don't know that part yet. So these are some other cases that we were involved with, but we didn't have to deliver hemodialysis, but I just want to show them to you because they bring to light the same challenges that our other colleagues deal with. And what do you do in these situations? So a patient with polysubstance abuse, episode of endocarditis secondary to IVDU, required a valve replacement, and then left AMA, returned with sepsis, was treated with antibiotics again, and then left AMA before finishing the course, and then returned sometime after with septic shock, endocarditis, and an incompetent valve. So what so with surgery, like do we redo surgery in this patient now when we know that that surgery is very, very high risk? So another case was a patient who, history of IVDU, was then diagnosed with lymphoma. Was started on chemotherapy, but then left AMA in the middle of the first cycle, was readmitted requesting treatment, and then started back on an altered regimen, but then left AMA again, and then returns 2 months later with progression of disease, wanting to live. So you can imagine the situation that the hematologist was confronted with. So how do you do chemotherapy, which requires vigilant follow-up in a situation like this, which may be unsafe? So identifying the challenges. This population is clearly at risk because their primary disease is not their renal disease, it's their substance use disorder. So how do we approach and manage their addiction? And how do we overcome the barriers to improve their outcome? What are the risks associated with providing this unconventional care? So does the surgeon do the repeat valve surgery and take on that risk? Do you do interrupted chemotherapy, which obviously requires vigilant follow-up? And what about doing interrupted dialysis treatment with these long interdialytic intervals? So what are these risks, and is the care team obliged to accept these risks directly associated with the treatment that they're providing? So of course we have to respect the autonomy of the patient, but what about the autonomy of the care provider who is responsible to do no harm? So I just want to go over what are some of the chronic dialysis options for patients. So clearly we know there's peritoneal dialysis, but unfortunately this is not an option for this population because it's a home therapy, and often they don't have a stable home. It's also self-administered. The patients have to actually do their own prescription, so it's usually not feasible in this population. So they're left with hemodialysis, and hemodialysis poses its own problems. So first of all, they don't have options for vascular access, so they're just left with the chronic hemoline, which poses its risk of infection. Plus, they can use it to inject, and we've had issues with overdose. As well, the recommended minimal dose for hemodialysis is 12 hours a week, because below this, mortality goes up. So some of these patients have some residual renal function, so they could start with twice a week, but it's not optimal long term. And there's a lot of risk associated with doing this sort of intermittent once a week and having this long interdialytic intervals, because you get accumulation of toxins, which then lead to these huge changes during the hemodialysis treatment. So non-adherence in dialysis patients refers to dietary non-adherence, where then they come in with these massive fluid overload, hyperkalemia, hyperphosphatemia. And the non-adherence to their dialysis prescription can mean anywhere from missing runs, not showing up for a few weeks, or coming late and just getting 1 hour, or leaving early. So when you have these large fluid gains, this poses a huge problem. We only have 4 hours, often 3 with them because they will leave early, and you have to take all this fluid off. So they get hemodynamic instability and collapse. You get cardiac stunning and ischemia. And these huge solute and water compartment shifts lead to disequilibrium and seizures, which I'll talk about in a few slides. And then these rapid electrolyte shifts as well, it's just potassium, can lead to fatal arrhythmias and cardiac arrest. So this is an article that was published in 2011 in the New England Journal of Medicine. I want to bring it to light for you guys. They looked at a huge cohort of patients that were receiving 3 times a week dialysis. So they were actually coming 3 times a week. And they wanted to see what was the risk of death or CV-related events on the first day, first hemodialysis of the week. So for the patients who do Monday, Wednesday, Friday, they wanted to see, do more events happen on the Monday after they've had the 2-day rest versus the other days of the week? And similarly for the Tuesday, Thursday, Saturday, do more events happen on the Tuesday? So again, this is only 2-day break. It's not a 10-day or 15-day break, which is usually what we're talking about in these cases. And you can see that the annualized mortality rate is significantly higher on that Monday, the first day of the week where they get their dialysis. So when they come for dialysis afterwards, they can die because they've had this huge change in the level of the electrolytes and the solutes. And the same thing goes for the other annualized CVD admission rates. So if you look at the arrhythmias for CHF, they're all higher on that first day of the week. This is again showing the same thing, and they just wanted to look and see if there was a difference when you broke it down into the subgroups. So the black circles refers to events on that first day of the week dialysis, and the open circles is the other days. So you can see for all the subgroups it's the same. There's a significant difference between. This is again reiterating the same thing. They looked at 400 cases of cardiac arrest over a 9-month period. And they showed that the cardiac arrests were definitely more frequent on the Monday hemodialysis sessions after the 2-day break. And they're twice as likely if there was a huge potassium gradient. So this is what we worry about. So let's talk a little bit about the pathophysiology of dialysis disequilibrium. I think most of you guys know this, the physiology of this. There's a lot of different theories, but essentially it comes to the reverse urea effect. So these patients have a huge solute load, and there's actually rapid solute shift from the extracellular space across the dialysis membrane. But the solutes move much slower from the cells. And this is actually accentuated in patients in uremia because the urea receptors that allow the movement out of the cell are downregulated, but the aquaporins that allow the movement of water across the cells are upregulated, so the water can move much easier. And you have this huge osmotic gradient, and now the water shifts into the brain cells and can cause cerebral edema. I just picked a few case reports. There's lots more of them, but I just wanted to bring to light how we always think of dialysis disequilibrium as occurring in a patient who's just starting dialysis, new start. But this case talks about a patient who's actually been on dialysis for 4 years, but they missed 4 hemodialysis treatments, just 4. And then they presented with hypertension over their goal weight and a high urea. And after 2 hours of dialysis, the patient became unresponsive. Hemodynamically was stable, intubated, transferred to the ICU, and then the CT scan showed diffuse edema, cerebral edema, and unfortunately there was herniation and this patient died. This is a case of a patient developing posterior reversible encephalopathy syndrome. So this is a syndrome that we often see with patients who present with severe hypertension, and they get this vasogenic cerebral edema, or it can happen with medications such as immunosuppressive medications or some infections. It's often not associated with dialysis disequilibrium. But this patient, again, who's not a brand new patient, was on dialysis for 2 years, but had not shown up for a 3-week period because he had developed some depression. He came to the hospital feeling unwell, 9 kilos over the goal weight, high potassium, and high urea. So he started on a slow hemodialysis, and being cognizant of the risk, they actually gave the patient a mannitol infusion to give him an osmotic load so that you would decrease the shifting of water over to the cells. 3-4 hours post-hemodialysis, the patient developed headache, blurry visions, complete visual loss bilaterally, hemodynamically stable, and this is what the MRI showed. So diffuse edema all the way to the subcortical areas involving the occipital lobes and some of the corpus callosum. So this patient stayed in hospital, received frequent dialysis, and fortunately after a week did improve. The MRI changes reversed. So now that I've given you a little bit of information about what can happen with intermittent dialysis and what the risks are, I want to now switch over to what are some of the factors that are associated with non-adherence in dialysis, and I'd like Allison to take on.
Okay, so one of the first things we want to look at are what are the factors involved in non-adherence to dialysis. So according to the National Kidney Foundation Dialysis Outcome and Quality Initiative guidelines, you need to look at the following factors: missed treatments, shortened treatments, so again, that's arriving late or leaving early, intradialytic weight gain, serum phosphorus, treatment adequacy, and again, it's really important to remember that the KT/V formula only talks about the efficacy of that one treatment. It doesn't actually speak to the patient's overall health, and you're going to want to look at any decreased serum albumin. And I'm sure, as most of you know, as the complexity and the duration of the medical regimen increases, the adherence decreases. So the more you ask a patient to do, the less of a chance it's going to be that they can follow through with all of it. So I wanted to take a look at the literature and see what the predictors of compliance were. And the first thing that I noticed was that there's an awful lot of demographic factors that do not predict non-adherence to dialysis. They just have nothing to do with it. And that includes gender, employment status, history of smoking, time on dialysis, and ethnicity. But there were three factors which consistently predicted non-adherence to dialysis, and that's people who are young. Older people are much better at adapting to the rules and the constraints of dialysis, being a current smoker, and using illicit drugs. Interestingly, there was only one factor that consistently predicted adherence to dialysis, and that was having a strong support network. And I thought that was really interesting. So now that we've talked about what the predictors are, what are some of the barriers to adherence to treatment? And I've kind of grouped them into two distinct groups. We've got the concrete barriers, and those are the ones that we can sort of anticipate and we can address proactively. So when you have someone who has poor health literacy, they may not understand that if they skip dialysis for 10 days and then they do a dialysis run, they're going to feel sicker after the run. And they're going to assume, I felt fine before and now I feel sick. This isn't good for me. And we can address that with some proactive education. If the issue is transportation, that's something we can predict and we can try and deal with before the runs. If somebody has cognitive impairment, if they have dementia and they don't realize it's Tuesday and they have a run that day, that's something we can also predict, and we can try and build a support network around them. If somebody has caregiver concerns, so if they just have young kids, they're a single parent, or they have a dependent adult with them and they just simply can't get to dialysis, that's something that we can predict and we can work with. There are more X factor barriers, and this is where I want to be really clear. There are some behaviors that are interpreted as noncompliance, but they actually stem from factors associated with low socioeconomic status and or factors outside of patient control, and you'll see that the most often with the X factor barriers. So one of the X factor barriers I've named is homelessness. Obviously, dialysis is very important, and it can be a priority for someone, but their first priority is always going to be, where am I going to sleep? Where am I going to be safe? What am I going to do? Food security ties into that because the literature actually shows that food in homeless shelters is really heavily salted. So if that's the only food that you have to eat, eating it will be in direct defiance of the dietary restrictions, but it's that or don't eat. So this is not a conscious, willful decision that the patient is making. This is literally the only option that they've got. I want to talk right now about vulnerable minority groups, particularly Canada's Aboriginal people. If you think about the Yukon, that entire territory doesn't have hemodialysis. So if you have end-stage renal failure up there, we are going to take you away from community, the only people that you know, move you to a city where it is easily 100 times larger than any town you've been in. We're going to take you to one of the most expensive cities in the world, and we're going to ask you to subsist on a disability allowance. And we're going to try and sell that to you as a great move for your health. So you can understand that there might be some trepidation there. And the following three, I want to be really clear, you can't view these as separate social determinants of health. For addiction, mental health, and trauma, the literature shows there's an awful lot of overlap in between, and so somebody's not overcoming just addiction. It's usually addiction and trauma, or addiction and trauma and mental health. So it's important to remember as providers that your patients are facing multiple barriers at the same time, and they need to be addressed together. So just to give you an idea of how important the social determinants of health are, the Canadian Medical Association published this pictorial, and it shows you that 50% of what influences your health are the social determinants of health. So things like income, early childhood development, disability, education, social exclusion, your social safety net, gender, your employment, race, Aboriginal status, safe and nutritious food, housing and homelessness, and community belonging. That is above and beyond the most influential factor on your health. Compare that to the next most influential, which is your health care. That is to say, your access to health care. If you live in a rural or remote area, your access to services is going to be really restricted. And even if you live in an urban area, you might have a long wait time to get the scans and the tests that you need. The third most influential is your actual biology. So your genetic makeup, your predisposition to disease, those are your individual risk factors. And you'd think that they'd be much more influential on your overall health, but it turns out that they're the third most influential. The only thing less influential than your individual risk factors is your environment. And then by that, we're talking about your air quality and civic infrastructure. So it's really important to remember that above everything, it's the social determinants of health that really determine how well your patient is going to be feeling. I wanted to take some time to specifically talk about addiction and mental health and how that works with dialysis. So the physical side effects of addiction and withdrawal will impact their ability to stay for a full run. So for example, they can wake up in the morning with every intention of wanting to go to dialysis. But if they use heroin, for example, they might sleep through their schedule. Even though they had intended to go and it was part of their plan, they didn't eventually make it. Or if you look at it from the other hand, they come to dialysis having used before. Dialysis will clear the substance out of their system. So about 2.5 to 3 hours into a 4-hour run, they're going to start to feel the effects of withdrawal, and they're going to be noticeably uncomfortable, and they're going to want to leave early, which I think is understandable. Also, I think it's really important to understand that addressing addictions needs may take priority over your hemodialysis. So the patients aren't going to be arguing with you. They're going to say, I know that this is important. I know that this is, and I want to be there. But when they wake up in the morning, their first priority might be staving off the cravings or staving off with withdrawal. And I actually found it was really interesting in the literature. I found a study from 2007 that says as many as 19% of hemodialysis patients have been diagnosed with a current substance use disorder. So if you think about it, that's almost 1 in 5. And I think we are experiencing an opioid crisis right now. And so it's only reasonable that you're going to see it start to pop up in different departments and different areas of specialty. And we're only going to see it continue. So we really need to be mindful of that as clinicians and maybe screen for it a little bit more carefully to try and help support these patients. I'm sure you all know that anxiety is associated with an increased use of healthcare services, so it's important to know that these are not kidney patients. They are medical patients who often have comorbid conditions, and they're seeing many specialists and many clinics outside of their time spent at the hospital for 3 days a week, 4 hours at a time. So they're spending an awful lot of time here. And you can understand how their concern and their anxiety around their health and their health care is increased. I'm sure you're also aware that, patients who have end-stage renal disease are perhaps not unreasonably and not unexpectedly often experiencing depression. And depression is associated with decreased compliance in medical treatment. And just as one last push to get you to understand that the social determinants of health can't be viewed individually, just a reminder that 25.7% of individuals with a serious mental illness also have a co-occurring substance use disorder of alcohol dependency. So patients are going to be facing multiple barriers at once, and it's important to remember that when you're trying to come up with a support plan. So what does this mean for your practice? When the patient is sitting in front of you and you're looking at the multifactorial parts of their life and you're trying to decide what the best thing is to do, there's only one thing that I would like you to remember. Ask for social work. This is what we do. I was going to go through all the different teams and support networks in the community, but to be honest, it would take a really long time and you probably wouldn't remember because there's too many. And so this is what we do for a living. We like to set up, we like to work collaboratively with the community. We like to work with support networks. Ask for us and we can try and set up a support system for the patients. So understanding now what some of the barriers are to people doing dialysis successfully and the risks of not adhering strictly to the dialysis regimen, we have to make sure that we as care providers, when offering it, are standing on a really solid framework of ethical decision making. And to talk about that, Stan's going to come up and talk to you about it.
Okay, so thanks, Ali. So wanting to share with you a little bit about the complexity of the patients we face, and I'm sure, like many of you in your daily practices, find that are increasing challenges in terms of how of the situations we're presented. And so, as you know, and you can see from Dr. Kiaii and Ali's presentations thus far, we're dealing with a population with complexity that requires a team-based approach. So I think back over my 30-year nursing career, and I think about this complexity, and I think about the populations I've worked with in dialysis, and I really can't think that, in my early start, that we often saw people with addiction in hemodialysis. But certainly, over the last probably 10 years, we certainly see an increasing prevalence of this and the challenges that go with this. And so we ask and we look for the resources and supports and the expertise that are far beyond that of the dialysis program. So as we know, in the 80s, we faced the AIDS crisis, and now we face the opioid crisis and its impact on patients, families, providers, and our healthcare system. We also face many challenges as the hemodialysis program in caring for patients with a large volume of patients. So some 130 patients come every day to the hemodialysis unit to receive life-sustaining treatment. This happens 24 hours, 7 days a week. Our environment is structured to provide care to patients in blocks to be most effective and efficient of our healthcare resources. And so that leaves often for little flexibility in what we can do. And as you know, you may experience in working with complex populations, aspects of healthcare where we are challenged and we need to think about what we were doing, how we were doing it, and perhaps questions whether we're acting in the best interest. And so when we look at that, we're faced with the difficult questions and look for answers and seek in a systematic way to look at an ethical framework for doing so. So this ethical framework is one that is actually currently being utilized by PHC, and in that we look to explore the issue or issues at hand and look to, more specifically to identify the stakeholders and who's involved within. We need to be conscious of our biases and their thoughts and feelings around the case that we have, and because we all come from a different place with different values. We need to also look at the various values and principles that are in play and look to see whether we're in conflict with those. We need to seek clarity around the facts, identify options around the various values and principles in terms of establishing good goals of care. We make a decision, we implement the decision, but more importantly, we need to evaluate the decision with the patients and providers in conjunction to see, are we moving in the right direction, and is this the best interest for all? So how do we go about doing this? Well, we use an ethical decision-making model that we can assist in our decision-making process. And by today's talk, this is by no means an ethical talk, but brings to light an approach to exploring the clinical issues that we face when we are conflicted. So I bring to you the Johnson model. I'm sure that many of you are familiar with this. And looking at these 4 quadrants in terms of how we go about exploring the issues at hand. So in the top left-hand corner, we look at the medical indications. So what are the medical indications that are we're currently being faced? And the principles that go with that, looking at are we doing and promoting wellness and doing no harm? We're looking to explore the medical problem. Is it an acute problem, a chronic problem? Is it reversible, emergent, or terminal? What are the goals of the treatment? And in what circumstances are medical treatments not likely to be successful? Moving further to the right, we look at patient preferences. So patient preferences in terms of looking at their self-determination, their autonomy and respect for that of freedom and choice. We also look to say, has the patient been informed of the risks and benefits of the treatment? Is the patient capable of making a decision? And if so, are they willing to forego or go on with the treatment? And if not capable, who is the temporary substitute decision maker and have we engaged them? So moving to the contextual factors, we look at the principles of justice and fairness. And so we look to see, are there any other parties, including other than providers and the patient, who have a legitimate interest in the clinical decision? Are there religious, cultural, or other influences that may impact the decision? And what are the legal issues that may face us in terms of these clinical decisions that we make? Does institutional affiliation create conflict that may influence clinical decision-making? And lastly, what are the resources that we have accessible to us to provide care? So lastly, we look at the quality of life. So quality of life is one of the things that we're looking at all of the principles in terms of promoting wellness, looking to do no harm as providers, and of course looking to, at respecting the autonomy of provider and patient. Prospects within of the treatment, we look to see, are they able to return to a normal life? Are there biases that are prejudices that our stakeholders hold? And do quality of life assessment raise any issues that might contribute to a change of the treatment, such as foregoing life-sustaining treatment? So as you can see, this is a very complicated process, and often, as you can see, it follows way beyond that of just the hemodialysis program. It requires a team approach in terms of us being able to guide decisions, and certainly I'm going to turn over to Dr. Kiaii to talk about what we look to propose.
So what we would like to propose as we move forward, because we are seeing more and more cases, challenging cases like this, is that when there's a patient who's actually identified as requiring now ongoing chronic dialysis, we like to have a consultative team from the hemodialysis program, which would include the hemodialysis doctor, or one of our clinical nurse leaders, or a nurse practitioner, and then one of our renal social workers who could actually go and see the patient and try to identify all the potential issues right up front. I think it's very important that we meet with the other specialists involved, so the addiction specialist, the psychiatrist, the infectious disease doctors, and the family doctor right up front, and meet with the patient so that we can make sure that there's a clear understanding of the importance of adhering to the dialysis schedule and what the implications are and what the risks are. And then work on developing a care plan with the patient and the rest of the team, and address all the issues and barriers right up front, and ensuring that the support systems are in place before the patient gets discharged and is supposed to come for their outpatient chronic hemodialysis, because this is hard, and hopefully this will set them up for success. And then we'd like to organize regular meetings with the teams involved, so with the addiction team, with the infectious disease team, just to make sure that the patient is doing well and there's no other ways that we can support to improve the outcome for them. And in some cases, we might find out that this is not the right thing for the patient. And sometimes the patients will tell us themselves, this is not good for me. It's not giving me good quality of life. So it's important to do that. We want to make sure that we come up with more forms to help the patients remember why it's important not to miss dialysis, what's the risks, and then do follow-up assessments. So like this is some examples of forms that are out there, and we have similar, maybe not as colorful, so hopefully we can change them, but just to sort of give to patients ongoing, just to remind them, what is the risks involved? Is it worth the risk to miss the dialysis? And hopefully maybe this will help. We've come up with this form to help us assess the patients as they are on the chronic program as an attendance improvement plan. And actually, Ali came up with this form that we're hopefully going to implement as a provincial thing in the future. So I'd like her to talk about it since she came up with it.
So this is a form that we would utilize with the patient and their identified support system. So we would want to connect with the community as much as possible, if that's friends, if that's family, if that's tenant support workers, whoever the patient identifies as their support, we would want to bring them into the hospital to meet with us as a team to say, okay, what can we do together? So the objective of the meeting is always going to be the same, to improve adherence to dialysis for better health outcome. And we start by looking at the background right here, and that's to take a look at what the attendance status shows us. Are they consistently missing runs? Are they coming late? Are they leaving early? Just to show us where we're starting from and how we can improve. The next section is asking the patient for their strengths and their interests, because we want to make sure that they feel engaged in the process and that they're involved in their treatment as well. And then we would like to ask in their own words, what is the barrier that they're facing that prevents them from getting to dialysis regularly and prevents them from adhering to the dietary restrictions or whatever the specific concerns are? We want to hear from them what they think the issue is. Then we want to hear what can they do to help address this, and then more importantly, what can we do as providers to help them address these barriers, to help make accessing care easier. And then we have an implementation date and a review date. And the last page is just sort of like a 3-week scorecard to let us know how we're doing. Is the patient showing up on time? Are they staying for their full run? Are they showing up for runs at all? How are we doing in our attempt to try and remove some of these barriers? And then we review it as a team after that.
Thank you. So we're coming towards the end of the talk, and actually I'd like to end the talk with a couple of cases that we were involved with that we feel that had a good outcome for the patient. So this is a 65-year-old male with a history of polysubstance abuse, HIV positive, hypertension, hepatitis C that was recently treated. He had end-stage renal disease secondary to FSGS, and initially we had huge problems with him missing runs, but we had a care plan initiated, and he was very fortunate that he had a very involved family doctor, an infectious disease specialist that really helped us. They met with him very regularly, met with us, and I think together we were able to really help the patient to change and put in the support systems for them. So he significantly improved his attendance, and he comes regularly now, 3 times a week, and he's been with us since 2014 and still dialyzing. This is another case that had a different outcome, but again, a good outcome because it was her choice. So she's a 57-year-old female, hepatitis C, hepatitis B positive, polysubstance abuse. She had recurrent skin infections and soft tissue infections, and she developed end-stage renal disease, and she had biopsy-proven amyloidosis, presumed from the infections. She started hemodialysis when she was an inpatient. After discharge, for 3 months, we attempted for her to come for chronic hemodialysis, but she just would fail to show up, despite all the support systems that we did put in place. So we actually had a team meeting with her, and the patient chose to come off hemodialysis. We gave her the option of follow-up with our kidney care clinic, but she eventually declined, so we referred her to palliative care. And I wanted to share with you guys the letter that she sent us after she withdrew from the program, and I'd like to read it out to you. So she wrote to us, "To the renal team at St. Paul's Hospital, to those of you who I have had the pleasure to come to know at a time in my life when it was thought to be the end, thank you, not just for what you have done for me through dialysis, but for the way you did it. Though names forever elude me, your faces and your kindness and your patience towards me will not soon be forgotten. Though I know I've tired everyone's patience and my constant lateness, you always treated me with the utmost kindness and respect that is not seen anywhere else. The world needs more people like you in it. Thank you." So I'd like to end here and open it up to questions.
I wonder if we could sort of take away some lessons from 10C, where we have basically the same population.
This is your...
Yes. So very difficult for them to manage, say, inpatient or intended by the antibiotics or years. But we have a good relationship with CTCT, computer centers, basically medical respite, additional housing that's supported, low barrier. Family, friends, and I think for this population, that also might be an option, right? So it has all the benefits of a supportive home life environment, none of the trappings of hospital, and hospital schedule, no matter those types of services.
Can I just comment? Of course. So, yes. Okay, so I think the question was that can we use some of the facilities that's used through the 10C program to help support these patients so that they don't have to stay in the hospital. So this is exactly what I'm trying to say with this talk. So I'm really happy that you brought that up, because I think up to now what's happened with a lot of these patients, they get discharged and they have to come for their chronic hemodialysis. And these other support things, we're not aware of all the things that are available through that you guys are aware of. And I think that's the key point, is that there is no way to look after these patients by ourselves. So we need the help of specialists like the team up on 10C, and to put in all the support systems and to really make sure that they have the best possible chance. So I'm happy you brought that up. And that's what I'm trying to say, is that from now on, this is the only way we can approach it. Right? Did you guys want to comment? Or no? Okay. Other questions? Yeah.
So what does it look like when you're trying to do the attendance improvement plan, when someone doesn't have any support? How do you work with them?
Well, I'm hoping that as we move forward, that the patient will have some identified support system before they even embark in a chronic hemodialysis program. So, you know, if they don't at that point, let's say they've come in and quickly had to start dialysis, that's what I'm trying to say, is that as we move forward, we have to make sure that we meet with the patient and find out what support systems can we get engaged for them. So if they don't have family here, perhaps they have other way of support, like yourself, right, that could be involved in their care, right? And it's up to the patient. They can let us know, and we can let them know, hopefully, what the resources are. Again, we need team involvement for that, to see what are the support systems that are all out there, and make sure that we engage them as we go along with their assessment, so that when it's the weekly time to meet, the rest of the team is there. And we do it together with the patient involved, right?
A lot of patients that we encounter have absolutely nobody.
Mm-hmm.
And so I was wondering.
Yeah. Did you?
I think the important piece is to remember that this is bigger than just us as a program around what we deliver as a service. And this requires the whole system to pitch in, to look after and connect people to those resources. So, you know, we work within the walls really well, but outside of the walls, that's where our challenge is. And there are often, you know, many resources that we perhaps don't even know about. And we need that extension into the community, because if you think about it, the patient is at dialysis for 12 hours a week. The other 156 hours of the week, they're in our community. And that's the piece where people live. So that's the part, if we're going to be successful, is where we're going to need to look at those connections.
Absolutely, yeah, up front, early. Any other questions? Yep.
I'm just wondering when you'll know when to start this type of improvement plan.
Well, pretty quickly. So, I mean, I think that the first thing is just to bring it up to light. And hopefully now what we can do is liaise with our colleagues, you know, and it starts right from the ICU to the addiction specialist, the psychiatrist, and just making sure to see who are the people that we liaise with. So, for example, if we have a case tomorrow that's identified as being discharged from 10C, let's say, who's going to need chronic dialysis, we'll make sure that we go up as a team to see them. So we're going to implement it immediately. And then we'll ask for who is going to the person who's going to be their addiction specialist, who's going to follow up with them. What's the support systems that are in place now? Get our social worker involved, right? And make sure that any other support stuff that's out there that we haven't engaged with already, that gets that they get involved right from the beginning. Yeah.
And I think it should actually be a bit smoother. I don't think we're going to be starting from scratch trying to build a bank of resources that we have, because we will be working closely with the teams that the patient is already working with. So, for example, when the patient's up on 10C, I can talk to the 10C social worker and say, okay, what resources are normally used by your team? What do you know that I don't? And it would be the same if I went to medicine, if I went to cardiac. What resources do you have that I don't know about that we can use here? And I can call on the wealth of information on a number of my colleagues, and they can help me out, and we can kind of make sure that the patient is adequately supported.
I mean, what was something that was interesting to me was when I was talking to Annabelle the other day and from Addiction Medicine, and she said, "Oh, I had no idea that you guys had so many of these patients that we were not involved with," which is right there the problem. So, I mean, I guess we were thought that their patient had some, but they didn't. So that's the thing we have to make sure. Mm-hmm. Mm-hmm. So I don't think that there's very good statistics really out there. I can tell you that in our dialysis program here, we have probably around 260 chronic hemodialysis patients that are dialyzing. And, probably close to 20-30% have issues like this. Now, some of them aren't as, they're already connected to some support systems, but we haven't really looked at all the outcomes in a proper way. So I think that we need to actually start to really look at this properly and see what our outcomes are. But generally, it's been case by case that we've unfortunately had real challenges to deliver good, safe dialysis and get good quality of life for the patient. So I don't know if you guys have any comments about, go ahead, Mary. Do you want to go microphone?
Sorry, I was just saying that there is literature out there quoting mortality rates in this patient population Canada-wide at certain centers and comparing it to the sort of baseline mortality rate of a hemodialysis patient if nothing were to change for this patient. So if all these things that we try to do doesn't bear out for them. So the average mortality for a new start on dialysis, all comers, as we know, in 1 year can be as high as 10 to 20%, 5 years, 50%. In this patient population, unfortunately, if they are not one of our success cases, the 1 year mortality is up to 80%. So the average survival of these patients is somewhere between 8 to 9 months.
Alex?
So I think it's more than just an issue of getting the patients connected to community programs, but also having you guys in the hospital and in your dialysis unit connect to the community programs as well. And I think that's key because then you'll actually be able to work with each other to optimize. I mean, for example, in the downtown east side and there are a lot of programs where there are outreach nurses and outreach social workers, right, who might be able to help you and the patients facilitate knowing when their dialysis days are and what their times are. As another example, when I had a patient who, let's say, was on going to the pharmacy every day for their methadone, and I knew that Thursday was the date for their CT scan, I would call the pharmacist ahead of time and say, when the patient comes in for their methadone, could you please remind them that today is their CT scan day? So there are lots of ways of working with what's already out there, but just getting connected.
Yeah, I mean, we do connect with a lot of community sources, but I think that needs to increase.
I think that, there are a lot of individual community teams that were existingly involved, and it's the patient who comes to us and who starts acutely, and there's no resources wrapped around them. So that's the piece in terms of when you leave the walls, what's going to happen? How do you connect those people? And that's the real challenge. If there isn't someone in the community to help them live the other 156 hours of the day and to get them to dialysis, we're not going to be any more successful with it. So that's the really challenge. We deal with the acute issue here in the hospital, but then they're going to go home, and how are they going to get here? Where are they going to live? How are they going to keep themselves in a state that's going to be allowing them to continue? And that's the repeated challenge we have with the population.
Yeah.
Just as a segue to Alex's comment, one of the questions I have is, do we want redundancy? So if, Alex, you have a patient that you know in the methadone, can we tap on you and your team to help bring these patients to dialysis, for example? Because I think that's part of it. We need help as a team. The dialysis process, as is a lot of our other treatments, is quite intense, requires a lot of follow-up, requires fluid evaluations, lab work evaluations. So as it is, it's quite intense, and I think we need some help with that. The other thing is that, for good or for bad, over the years, teams have not come to hemo to do consultations. We understand that. Our program is too big. Patients have to go to the consultant. The consultants don't come to the outpatient unit. It is an outpatient unit, and we get that. But this patient population needs teams to come to hemo because they are captured on hemodialysis. And so, if we call a service and we hear, no, I'm sorry, they're going to have to come to my office, that's not going to happen. So either we decide as a team that we work together and we provide them with all the care that they need, or we accept that they don't get that care. And so I know that in speaking with addictions, you've offered to come and meet with our patient when she's there. Same with psychiatry has offered to come and see our patient. And I think that's going to be crucial in terms of making sure they get the right methadone dose on dialysis so they don't stop their treatment, to make sure that the outpatient team that tries to track them down knows they're not coming to dialysis.
Yeah, no, I think that's a great point, Linda. There's no way we can do this without the help of our colleagues. We are not addiction specialists, and so I think that you're absolutely right. Yeah.
And I would just say, Infectious Diseases has been really supportive in terms of coming to the unit as an outpatient to see our outpatients, to help us in terms of guiding therapy and treatment, because patients may choose not to come. And so then what do we do? What kind of a treatment regimen are we going to give them? Are we going to step them down? And so that piece has been really, really helpful and supportive in terms of the patient population, in terms of getting them care in a timely fashion without having them to organize many, many different appointments to do so.
What about living with the dialysis?
So there's a huge amount of support and funding that goes into creating a dialysis unit. So that would be a huge thing that we would have to see. Yes, that's right. Except, even making a community unit, trying to get a unit close to patients' homes is hard enough. Monica could probably comment more about this, but it's a huge endeavor to create a hemodialysis unit with all the things that go into, like the water supply, the water treatment. It's a lot of money. I'm not sure that's something that's easily.
Yeah, I guess if it was just about money, we probably could figure it out. I think that it sounds to many people like a practical solution. A community dialysis unit is somewhere where stable people go to dialyze, with a nurse and a physician that comes every few weeks to see those patients. So I don't think location and proximity is actually the barrier to these patients, and whether it's here or 3 blocks down the street.
Yeah, we're pretty close
it
right
actually
now.
isn't barriers to the patient and to the location. People from the east side actually have the least distance traveled than anyone. If it was that easy, we would do it. Yeah.
And other sites, certainly have colleagues across Canada who have dialysis units that are right in the downtown core, still face the same challenges we do in other major cities. So proximity isn't necessarily the answer. There's a whole lot of other factors around the patient population that we need to look outside of just the dialysis center.
I don't find that see that. That's sort of a discussion. So we literally have patients that go to CT over there for 3 months. That's their home for 3 months. They have IV product 3 times a day. Right? They have their partners over. They can use their room. Nursing home care, excludes meals, because they know and they want that health care. They know they can't get it at home. They don't want to come to hospital. So it's not about a community going outpatient. That's not it at all. It's residential transition. So it's a place that's run by the community, so it feels like it's very much accessible to people. Right? Wrapped in addiction care, social care, right? It's very approachable, and they have great outcomes for our patients. Easy referral.
Yeah, I think you're pointing out exactly what we're trying to say, is that these patients need follow-up and involvement of the specialist, the addiction specialist, right? So a lot of times this hasn't happened, right? And so the patients get discharged, we're the dialysis doctors. They come. We don't even know who was your addiction specialist. Did you even have one? So I'm not sure how this happens when the patients actually get discharged from the hospital. But this unfortunately continues to happen. So that's what I think we have to do, is make sure that we involve our colleagues like yourself to said, okay, how do we make sure all this stuff is in place, right?
And I think the other part is timeliness. So, if the patient's going to be discharged, where are they going to go? Are they going to be able to access that resource on discharge, or are they going to have to wait? Because we all know there's a fixed amount of resources available. And so you may have that direct access to that, but, is there a greater need? And if so, then there's obviously a whole new set of things around that around supporting that. So it's a concept, great, but beyond that, there's a lot more planning and resources that need to be thought about.
I guess I just wanted some clarification in terms of, were you anticipating that they would dialyze in CT-CT?
Yeah.
Oh, I don't think that's.
Well, I'm not sure as it currently is right now, but this is long-term problem. This problem isn't going away, right?
Right.
So in 5 years, could you practically envision transitional care unit, medical respite residential unit, the bridge, outpatient, acute, right? Dr. Peter Center does the CT. We didn't do it for infectious disease, right? But
I guess it would just be a bit of a stopgap, right? Because if you're only there for 3 months, you're going to need dialysis for years if you're a candidate for a transplant. So I guess my question would be...
a place where they could stabilize, right? I mean, you're not going to solve all the world's problems.
But dialysis patients, they need access to radiology, and they have access issues. There's a lot of stuff, especially in that first acute period. I mean, a lot of our patients who don't have any of the other issues that we've identified today, and they are absolutely candidates to go to a community dialysis unit, we keep them in center for a while until we've stabilized a whole bunch of different things before they can actually go to the community, because they have to access so many different things in the hospital. So I think that would be really difficult. I mean, if we could do that, we'd love to have it in so many different places. For the elderly patients, that's difficult. But it's just, they require too many other things, yeah.
Just to your point, because at one point, you brought up the concept of the benefit of a CTCT is that you're not really confined to a schedule. What we can't necessarily do as well in hemodialysis is we don't do dialysis on demand, right? So I think part of the presentation today is dialysis on demand is actually dangerous to the patient and requires often a higher level of care. So although it would be great if we could provide therapy in everyone's home for everyone, it's just not a realistic option, right? Dialysis on demand is actually dangerous.
Mm-hmm. Oops. Hi, Annabelle Mead from Addictions. So just a few comments. Yes, the CT-CT model is short-term and is not going to be a long-term answer. Obviously, it's only 10 beds and it's very labour-intensive. So nice if we could do that long-term, but that's problematic. The only way that our patients with severe substance use disorders are going to do well is if they are able to engage in ongoing addiction care. And so this is our big problem. We can often engage people short-term when they're in the hospital, but this drop-off from addiction care is very problematic. What we're seeing with the opiate overdose crisis is that we've increased our range of options for particularly opiate use disorder management. So that now includes Cadian and injectable opiate agonist therapy. So we're seeing a lot more patients on those treatments. And I'm just curious if you have had any patients at all on IOT that have been successful in long-term dialysis. And I think I'm thinking that perhaps those patients, certainly on Cadian, is not appropriate for hemodialysis, and likely IOT would be very challenging. So again, it limits our options for treatment. Mm-hmm. The best way of getting somebody into good, stable treatment is opiate agonist therapy with Suboxone or methadone, and also a time in residential supportive recovery or treatment. Mm-hmm. Any patients on IOT? Sorry, that was my question.
We don't have any at present.
No. Yeah.
And as you say, Cadian isn't an option because of the metabolite issue that will accumulate over time. Yeah. It certainly is a challenge, as you say. We have had patients on Suboxone and hydromorphone and methadone. But obviously, we see the same pattern in terms of whether or not they, go in for the daily witness dispense or not. And there's various periods of stability in terms of how well they're doing at various times, based on factors that happen within their life. So.
I think it's super important that we engage quickly, though, and we certainly, I can speak on the rest of my team that we can do consults, very quickly with patients as outpatients on the hemodialysis unit.
That's a good question.
Yeah.
Sure. Can I just ask a question, because we don't often have the chance to speak with addiction specialists?
Hopefully we will more in future.
if the patient cannot engage with the addictions team, how can we expect them to engage with the medical team?
That's my point exactly. Prognosis is going to be very poor for those patients. So we have to do everything that we can when they're in here and when we can have access to them to engage in care.
Sorry, final question.
I'm just thinking about this, like the timeliness of needing to engage in resources both in hospital and in the community. And I wonder if there's like a role from the dialysis or the nephrology team to take a presentation like this and do some outreach with like the intensive case management teams in the community, talk about like what is expected in a dialysis program and what are the barriers that you guys see, and try to build some of those relationships so that while folks are in hospital, we can quickly mobilize that team in the community.
Yeah.
Because sometimes that can take like weeks really for someone to get assigned a case manager, that kind of thing, right? So if they know a bit more about the context of what does new dialysis look like and what is important in the very short term, maybe that can help to mobilize.
Yep, and I think that's a very good advice.
So thank you, team, for presenting, and Merry Christmas to everybody.
I'm just deleting the slide.
Okay.
Well done, thank you. Well done. Thank you. Oh, hi,
I know everybody. We really want to take there's a couple of issues, and it's actually
will be disconnected.